Okay, well, it looks like we have a critical mass. So, good morning, good afternoon, good evening, no matter where you are. Welcome to International Medical Corps' first global briefing of 2026. I'm Rebecca Milner, International Medical Corps' Chief Advancement Officer, and I'd like to thank you for joining us today. I know everybody's incredibly busy, but we appreciate you spending some time with us. And many of you on the call are longtime supporters, and we thank you for your generous support that makes our work possible. So today, we're going to focus on one of the most powerful drivers of lasting humanitarian impact, training. But before we dive into our session today, given the widening conflict in the Middle East, I wanted to share a quick update. As you know, International Medical Corps has a deep and long-standing presence across the region, including in Gaza, Lebanon, Syria, Jordan, Iraq, Afghanistan, Pakistan, and Yemen. All of our team members are safe so far and are standing ready to respond to any impacts in their countries. Our teams in Lebanon are already actively responding, supporting a nationwide network of more than 40 primary healthcare centers. And we remain poised to rapidly expand our efforts, both within and beyond our existing footprint as the needs evolve. So I would encourage you to visit our website and follow us on social media to stay up to date and learn more. And we'll continue to keep you updated. But back to our session today on the power of training. As we always try to do, we're going to keep our briefing as efficient as possible. Our session's going to be 45 minutes long, which will enable our experts to go into a bit of detail and to give you a chance to ask any questions you may have. As we talk, please type your questions in the Zoom Q&A, and we'll do our best to get to them. If we're not able to cover them during our time today, we'll follow up with you directly. Since our founding in 1984, there's been a single constant that underpins everything International Medical Corps does, and that is the importance of training. Our training and capacity strengthening work increases resilience by equipping national and regional health systems, frontline health workers, community leaders, and partners with the skills they need to immediately respond when emergency strikes, the skills they need to support long-term recovery, and the skills they need to better prepare for the next disaster. And we do this at scale. Our team members, the vast majority of whom come from the communities we serve, train tens of thousands of people each year. In 2025 alone, we trained more than 72,000 people, helping them and their communities move from relief to self-reliance. I should also note that this work has really long-term and far-reaching effects. Each person we train brings the skills they gain back to their community where others benefit from their knowledge. Our training programs have a multiplier effect, meaning that the knowledge can spread throughout a community and indeed throughout an entire country, like ripples in a pond, reaching many people over many years. I'm happy to have three colleagues with me today who are directly involved with our training efforts around the world and who can explain how we're helping communities better prepare for disasters and become more resilient. Let me first start with Dr. John Roberts. JR is an emergency physician and public health practitioner specializing in humanitarian assistance and disaster response, and he serves as a senior technical advisor for our emergency response unit. Welcome, JR. We also have Lauren Bellhouse. Lauren is a senior advisor in our maternal and newborn health unit and is a global health professional with some 15 years of experience working both in development and humanitarian settings. We also are welcoming Erica Tavares. Erica leads our programming in the United States, and she also oversees a global portfolio designed to build the capacity of local and community-based organizations. So in both of these roles, she and her teams work to increase access to health services and provide training for organizations and individuals to help them better prepare and respond to disasters. All three of my colleagues have deployed with International Medical Corps as part of our responses, and all of them have experience providing the training that's at the core of what we do. So welcome everyone, and let's get started. JR, I know that our teams conduct a variety of needs assessments to find out what kind of training is needed, and that we also have really close relationships with ministries of health in these countries so that we can kind of align with their priorities. And you've been involved in providing training in conflict zones and natural disasters. Maybe you could talk a little bit about how we design and conduct training that's appropriate for each environment, and where there might be security challenges, where infrastructure is damaged, where the setting is so remote that it's really challenging to work. Maybe you can talk a little bit about how we customize our training programs.
Sure. So this is something I love talking about because every place that we do training is different.
Yeah.
The first thing that we have to have is that we have a suite of experts in different things. So whether it's the technical content that's being delivered or the context in which it's being delivered, whether it's experts in developing programming, logistics, finance, security, human resources, we have all of those experts that contribute to a project because we need all of that type of information to be able to contextualize our training. And so what we do is we ask ourselves three questions. What is needed, who needs it, and how do they need it? So in terms of what is needed, when we look at a conflict area, we may need trauma training. When we look at a very remote area without any medical services, we may look at something like basic emergency care training. If we look at a context that has multiple different mass casualties, we may go to mass casualty training. Whatever the gap is, similar to other programming, non-training, we look at the gap, we identify it, and then we fill it. And so that's
Mhm.
kind of looking at what is needed. The next
Yeah.
thing is who needs it. Is it doctors that need to be trained? Is it nurses that need to be trained? Is it lay people that need to be trained? Is it the folks on the street? Excuse me. And then where are those people? Are they in a hospital? Are they in a clinic? Are they sitting at home? Who those people are and where they are is really important. And then the last thing is, how do they need to be taught? So are they in the middle of a big city with Wi-Fi access and the ability to use a computer?
Mhm.
Or are they in the middle of nowhere and they need somebody that's in front of them? Do they need something? Do they need security considerations? Do we need to bring everybody to the same place and house them? Or can we do it in the community? What
Mhm.
language? And then what level of teaching? Are we dealing with experts in their field, or are we dealing with folks that may not even have may not have a grasp on reading? All of those
Mhm.
things go into how we contextualize our training.
Right. Well, and one of the most recent trainings that you participated in was in Nigeria. Maybe you could kind of give us a little sense of that training program that you most recently participated in.
Absolutely. And I actually think that Nigeria and Chad are really two really good examples because they're very different.
Mm.
We recently just completed some training in Nigeria and some training in the country of Chad. Both of them were similar in terms of their content, but the context was very different. So, for
Mm.
instance, in Nigeria, we were in an area where it was highly insecure. We were in Northeast Nigeria, where a lot of the unfortunate news comes out of. So everybody had to be in the same place in a compound with walls up, but everybody had really good internet. And so we delivered three different trainings. We delivered basic emergency care, we delivered mass casualty management training, and we delivered Stop the Bleed.
Mm.
Stop the Bleed is an in-person course for lay people, for your mom, for your dad, for the drivers, for the security folks to stop bleeding. Basic emergency care is for primary care and other non-emergency specialists to learn how to deliver emergency care when it's needed in a hospital or in a pre-hospital setting. And then mass casualty management is not a clinical course at all. It's how to train folks that are leading an emergency unit to develop a mass casualty plan and how to implement that plan in their own facilities. And so we were able to do a lot of hybrid and pre-work with this group of folks because they had a lot really good internet access. And
Mhm.
although it was an insecure environment, our ability to bring supplies and resources to that area was actually very good. I contrast that with Chad. Chad is also insecure, but not as acutely insecure. So the security protocols needed to be less robust. We were able to keep people out in the community while in between trainings. And but where we were training didn't have any internet access and only had electricity for 4 hours a day.
Mhm.
You can see it's very different, same
Right.
exact
But the
content,
same courses, but you were teaching the same.
exact same courses, exact same
Mhm.
courses. Oh, also the Nigerians speak largely English and Chadians speak largely French. And so
Mhm.
the courses in Nigeria were done in English and the ones in Chad were done in French. So same exact program, completely different experiences for people.
Yeah, yeah. I mean, it sounds so simple to deliver a training course, but when you're grappling with all of those issues, it makes it a little bit more complicated, and there's a lot that goes into it.
Yeah.
Well, Lauren, let's talk a little bit about maternal and child health. I mean, I know that the global health community has made tremendous progress in bringing down levels of maternal and infant mortality in the last few decades, right? But of course, there are way too many mothers and children that are dying. And in fact, two-thirds of the current maternal deaths occur in humanitarian settings, right? So in fragile contexts and places where they're experiencing insecurity. And so, how can we leverage the progress that the global community has made and to make sure that people in these humanitarian settings have access to the knowledge and skills that they need to help mothers and babies survive? Maybe you could talk a little bit about that.
Absolutely. So first of all, thank you. I'm really happy to be here speaking with everyone about the great work our teams are doing. And you're correct. We are thankfully making great strides in bringing down maternal and newborn mortality globally, but we are seeing that fragile and conflict affected settings aren't really seeing the same results.
Mm,
Sometimes this is entire countries that are affected, and often it's sort of subnational settings where there may be a country that in general is making progress and maybe introducing new innovations or updating their guidelines so that healthcare workers have the most up-to-date training. And we're seeing that that just doesn't reach the settings where we work, the humanitarian context, whether that's access challenges or political sort of issues that make it hard for ministries of health to do that themselves. That is where we come in as a humanitarian actor. And so, we're thankfully able to access areas where, uh, as you said, two-thirds of the maternal deaths are happening and 50% of the newborn deaths. And that's only about 30 countries that are included in what we consider what we're putting into that statistic. So if you think
mhm.
about 30 countries making up half of the newborn deaths, I mean, there's a lot of work that we can be doing there. And it's important to note that maternal mortality is something that we can solve. It's not some nebulous issue where we really don't know what to do. We have the tools. It's really about making it happen. And the piece around healthcare worker support and training is key because the World Health Organization has actually estimated that we could reduce maternal deaths by 70% just by ensuring that every woman has access to a skilled birth attendant providing good care at birth. And that's not always feasible depending on the geography of a region. If healthcare
Right.
workers have left to go to safer areas, if it's inaccessible to standard systems. And so this is where International Medical Corps is stepping in and really trying to build on what a country is already doing and also replicating what we may be doing in other countries with similar contexts that are working so that we can make sure that the healthcare workers we're working with that are providing the care for mothers and their newborns are feel confident and are able to provide the best quality care possible.
Right. And I think one of the things that's really interesting about the work that we're doing for maternal care is not only we do the training itself, but we provide the on-the-job supervision. And maybe you could to reinforce the training that
Sure.
each cohort goes through. So maybe you could talk a little bit about those two components and how they're really important. You can't
Sure.
really just do one without the other, right? You need to reinforce.
Absolutely. We really try not to, or we don't, sort of train and walk away. There's actually really two sort of avenues of training that we support at International Medical Corps. The first is sort of helping provide the formative training for midwives, midwifery assistants, nurses in some of the more challenging contexts where these schools might not exist, as the case was in South Sudan at independence. There were no nursing and midwifery schools. There were only 6 midwives in the country, and we worked with the Ministry of Health to set up 4 midwifery schools that have now trained over 700 midwives. Some of them I've met, and they're now running our IMC clinics and some of the IDP and refugee camps. So it's really an achievement. And of course, where we do that, we continue to provide that in-service, on-the-job skill refresher training to those midwives where we have provided their sort of formative certification training. There's also, on the other side, there's this in-service, on-the-job training that we provide even in countries where we don't necessarily have a midwifery school that we've set up. But if we are supporting a health facility, I can guarantee we're also supporting capacity building of the healthcare workers who are working there. And the way we would do this is by clinical trainings, largely on the job on site, or sometimes it might be bringing, expert trainers that are identified from facilities somewhere for a training of trainers, helping to cascade that out to more regional facilities. And then our International Medical Corps health and maternal newborn health experts will go around after the training is completed and everyone's been certified and go directly to those facilities, work with the people who've been trained, the healthcare workers, answer any questions they may have, clarify any misunderstandings that might have arisen during the trainings, and just make sure that they're keeping up that skill level and the confidence to be able to continue to provide those services. So it's really not a one-time point sort of thing. It's across the career of a healthcare worker that we're supporting. Yeah, it's really exciting to see.
Right, right. And maybe you could touch on a little bit some of the innovations that are working in places where maybe it's low resource setting, but it's secure. But maybe we're trying to adapt some of those innovations for these insecure humanitarian contexts. Maybe you could talk a little bit about that because, like you said, there's so much progress, but we don't want to leave these countries behind.
Yes, and there's so much talk about innovation in maternal and newborn health right now, and it's incredibly important and it's exciting to see the progress that's being made. But as you said, we are sort of noticing that certain areas are being left behind in rolling this out. It's something that we have decided to sort of try to spearhead rolling these out in through training approaches in some of our settings. So, for example, in Yemen, we were able to bring 15 female OBGYNs and obstetricians and pediatricians outside of Yemen to UAE. We brought in specialists that were covering a package of 10 different maternal newborn health innovations, things like a point of care ultrasound that you can plug the scope into your phone, and the midwife could go to someone's house and provide on-site ultrasound there. Things like the WHO's most updated guidance on treating excessive bleeding after birth, which is the number one cause of death for women globally and also in Yemen. And so they got this package of services, were able to go back in country and cascade that training along with International Medical Corps support for the supplies and also training support, supporting the Ministry of Health trainers to cascade that training to over 25 facilities. So we've reached hundreds of healthcare workers now with these innovations. And this is the first time that they've been rolled out in Yemen. We're working closely with the ministry, and we're also now thinking about this is working. People are really appreciating these new services or these new tools that are being used in other more secure contexts. And just because a country is experiencing security challenges, it doesn't mean that the mothers and the newborns, deserve lesser care. So how
Right.
can we take those learnings on the training success there and replicate it in some of our other settings? So we are
Right.
looking forward to that.
Yeah. Yeah. Well, Erica, I mean, we've almost exclusively talked about humanitarian contexts, but there are some
Mhm.
significant challenges here in the United States, especially when it comes to disaster response.
Mhm.
And I think we've really kind of experienced that over the last, well, I mean, COVID and then,
Right.
these outbreaks and natural disasters. But maybe you could talk a little bit about the US system and some of the gaps that exist that we're trying to fill.
Sure. Sure. Thank you so much for the question, and thank you to everybody for joining us today. And I think, a lot of what we have been doing and working on increasingly in the U.S. is bringing a lot of the training approaches that JR and Lauren are talking about to settings in the United States that need them, particularly when there's a disaster. So the U.S. response system, the disaster response system here, is set up to largely deal with the disaster itself, to respond to the actual event, whether that's putting out wildfires, responding to the site of an earthquake, and then to provide food, water, and shelter in the immediate aftermath. However, what we're finding is that the needs are really stretching far beyond that. Traditionally, healthcare, the provision of healthcare in the immediate aftermath of an emergency, has been the job of the hospital system. It's assumed that an emergency room will be able to take on the surge from the event, what those immediate needs might be, and will be able to meet that healthcare need. However, unfortunately, what we're finding with the scale and the severity and the number of disasters that we're seeing in the United States, that people are displaced from their homes, or they're in shelters, or they're cut off from care, or hospitals just can't meet the need. They themselves are affected for sometimes days and weeks at a time. I think, the Hurricane Helene highlighted this. When Western North Carolina went for weeks with some areas without power. I think we saw this in California after the wildfires as well, where there were people in shelters for almost 2 months. And that presents a whole separate and new set of healthcare challenges. And one of the things that we're able to do is, just like JR was saying, when we're thinking about who needs training, what do they need, and, sort of where and how do they need it, we're able to bring in a lot of the experience that we have internationally, because we're used to providing healthcare in non-traditional or alternative sites in ways where you don't have necessarily all the resources that you're used to. We have some of the best healthcare in the world in this country, but we're also all very used to receiving it and delivering it in a very specific, in a healthcare facility, in a hospital. And I
Right.
think, right, so if you're in a rural area where hospitals are closing and the nearest hospital may be hours away, or if you're in a setting like we were in the Pasadena Convention Center where there's an outbreak, we do need to provide some of that, what Lauren was describing, sort of in service, on the job, just in time training to help get the systems up and running, and to use the knowledge that we have in different ways, and engage the healthcare workers that are on the ground in that, the ones who know their communities best, but may not know how to use the skills that they have, the assets they have, in a little bit of a different way to meet the need in front of them.
Right, right. So the gap is that the health care providers aren't used to working in these environments, but
Right.
yet more and more frequently they're being called on to do this.
Yes.
So talk a little bit about some of the training that we're doing with these federally qualified health clinics, the
Mhm.
rural hospitals, et cetera, to help them be better prepared for when
Sure.
the disaster strikes.
Right. Right. And that's exactly right. The community clinics that we often work with, they serve the most vulnerable populations, the most at risk. 30 million Americans look to them for their healthcare needs. But they're primary care facilities. They're not designed to provide emergency response care. Yet we also know when a disaster happens, this is where people are showing up. One of our partners in St. Louis noted after some of the tornadoes last year, they had people in their parking lot looking for services and needs within 30 minutes.
Wow.
And they themselves had just gone through the tornadoes.
True.
They were worried about, right, they were affected. They're worried about their own families. And so a lot of the training that we provide longer term in the United States with healthcare facilities is really is how to look at your systems, and to look at the the tools that you have, the health workers you have, and figure out how to put an emergency plan in place in order to be able to effectively respond very quickly when a disaster does happen. And that could be everything from a natural disaster to a disease outbreak, to an active shooter incident that might happen very locally. And so, how are you going to make sure that your staff know what to do when there's a disaster, that you have the resources available, that you have the plans, that those plans are exercised, that they're not just sitting on a shelf after they're developed, that you have the funding and the resources to roll it out. And a lot of what we talked with them about too is developing the right kinds of partnerships with other organizations so that they can be as effective and efficient as possible. Because not some of these facilities are quite large, some are quite small. They have a few dozen healthcare staff, and so they need to borrow resources from another facility. So how do you create those kinds of partnerships as well?
Mm-hmm.
And so, we'll deliver that sort of in the aftermath of a disaster, because this idea of investing in training, right, it's not one time, right? It's not going in and you provide a clinical training and you leave, but how do you really help develop, implement those plans, provide that knowledge, support health workers or their management staff through that, so that they're better prepared for the next event that needs.
Right. Well, JR, coming back to sort of the development of the training. I mean, like, we see gaps kind of everywhere, right? I mean, and so talk a little bit about how International Medical Corps kind of evaluates these gaps and then customizes training to meet those needs. But then, for the immediate gaps, but then how do we work on ensuring quality care over the long term? And it's a little connected to some of the things that Lauren was saying.
I was actually going to say Lauren did a great job of setting me up. Thank you, Lauren. What finding gaps in services and finding gaps in what people need is what we do. We never try to develop a parallel system of healthcare, of nutrition, of protection. We try to find what's not being done and doing that. So it starts with the things that we do every day, which is finding the seams and trying to do our best to bridge the gap between where people should be and where they are. So the first thing is having a knowledge of the context in which you're going to work, whether that is from longstanding pre-existing programming, like a lot of the country missions that Lauren supports, or by understanding disasters in general, like my unit does. We know we're able to predict and to anticipate what is going to be needed, regardless of whether we've actually been in a place for a long period of time or not. And so looking at the short term, we identify what needs to happen and what needs to be taught, like we talked about earlier, and we teach what is needed as efficiently as possible where the people are. And so that's how you get it done in the short term. In the medium term, we almost always perform what we call a rapid cascade model. I'm an emergency response unit, so everything that we do is rapid. Everything we do is rapid. It's an emergency. So we've developed what we call a rapid cascade model of training, which is when we go into a place that needs a specific type of training, we set up a training course for the most highly skilled people that will be trained, and then we immediately put them through a training of trainers within days of the first course. And then what we do is we immediately take those trainers and then we have them train other people immediately after that, under our supervision.
Right.
Exactly.
Okay.
So we have our master trainers that train the folks that are going to be that are well positioned to cascade that training, and then immediately put them through that supervised training. So we create what we call registered instructors. So at the end of this, you come out with not only folks that have been trained, but also folks that are now able to perform that, to cascade that training to other people, and we know that they're able to do it with a high level of quality, because that's what you're always worried about. You're worried that the quality is going to get diluted over a while because you're not practicing this thing. So you put people immediately through practice, and then so that's the medium term. The long term is what Lauren was talking about. We never train people and then leave. So the emergency response unit's policy is to always perform rapid cascade training and then also to leave those new instructors with all of the supplies and the equipment that we came into the country with. So that group of folks now not only has the ability, not only has been trained to be an instructor, not only has been an instructor, but now has all of the things to go forward and instruct. And we perform what Lauren was talking about earlier, supportive supervision for them to go forward and do that. So we maintain long-term contact with the training cohort, and we are able to help them through problems that they may run into. We're able to help them to create a new course. And then the last thing is that the system that we've created over the course of years, we actually give them a version of that system that decreases the amount of effort on their part to be able to cascade it. And so that short and that medium and then that long term window, we're able to ensure that that knowledge is not going to sit on a shelf, but that knowledge is going to be spread from there.
Yeah, yeah. Well, and Lauren, one of the questions that I have is about, I mean, so we do the what we call the pre-service training, like the formal educational training that we do, whether it's in South Sudan or CAR or Afghanistan. And then we do the on-the-job kind of training and reinforcement and the short term versus with the thing. But maybe you could talk a little bit about some of the community outreach that we have to do. I mean, it's essentially training, right? But the importance of engaging community members in, accessing healthcare and even good practices that will help them be healthier. So maybe you could talk a little bit about that piece of the training.
Absolutely, yes. And this is really critical because if we set up services and people do not know that they're there or don't necessarily understand the importance or understand the importance but think there are other priorities they're juggling, the services might not get utilized. And so it's a sort of an extension of the service provision is going out into the community, whether that is IMC staff themselves, healthcare workers at facilities that we're supporting. Sometimes there is a community health worker structure in place. And if that's the case, we love to support that and help make the community health workers feel even stronger and more capable to provide services and information. And so we will provide trainings for community health workers, maybe for traditional leaders or religious leaders, on things like the importance of giving birth with a skilled birth attendant at a health facility, or the importance of going for prenatal care, danger signs to look for in a new infant that might mean you should go get them checked out at the health facility or by a midwife. And so we will train some of the leaders in the community and support them to go out and provide these messages in different fora. So whether it's community meetings, community centers, traditional sort of religious settings. It really is context specific. It depends on, and this is part of what we do in that initial sort of rapid needs assessment, where we look for those entry points. Who should we be, reaching out to the community through, and where should we be doing it? And so putting that in place is really important for letting people both know about the services. For example, ahead of a mobile medical unit that might be coming through, we want people in the areas around that mobile, health service unit. We want them to know that they should be here at this point in this village in the next 2 weeks. You can receive this type of care. So that's just one example, but it's important for letting people know about the services and also some of that behavior change to encourage people to utilize these maternal newborn health services.
Right. Well, I mean, we've talked a lot of kind of, concepts. We've talked about a lot of concepts and how it is. But, maybe you could each kind of talk about one person or one training that you participated in or that just help make it real for our listeners on the call. Maybe Lauren, you wanna start with somebody that you have worked with and the impact of the training?
Sure. There are so many. I'm thankful for that. But I was actually thinking about this doctor the other day, so I'll speak about her. But I met a doctor in Nikopol, Ukraine, which is right on the front line. There's Nikopol, there's the river, and this is the front line. There are a lot of incoming air assaults that are happening hourly. And this doctor is actually a retired podiatrist who was happily retired. And many of the younger doctors in the entire area of Nikopol had gone towards the west where it was a bit safer to practice and for their families. And so she realized there was nobody in the village that she was in or anywhere nearby to provide healthcare for people. And so she came out of retirement and sort of was acting as the general physician at one of the health facilities that IMC came and started to support. And when I went and was speaking with her and doing sort of a needs assessment, she expressed to me that one of the needs was that she felt really nervous about caring for pregnant women and newborns because that hadn't been a part of her training. She was a podiatrist and she really wanted to be able to provide good care, but she just did not feel comfortable. And these women weren't able to travel to a higher level hospital and see a specialist if they were even there because it just wasn't safe with the airstrikes. So through some of our initiatives to bring these services, the maternal and newborn health services, closer to the communities in the eastern part of Ukraine, we were able to provide her with training for antenatal care, postnatal care, prenatal and postnatal care, how to do emergency safe delivery if necessary. And the second time I was able to meet her, she was so confident. She was showing me, how many women that were pregnant she'd been able to safely care for. And it was just really exciting to be able to see how confident she felt to provide services to her community in a really challenging situation. So that is why we continue to do the work. So.
Wow, amazing story. Erica, what about you? Some of
Sure.
the groups that you've encountered.
Yeah. I mean, I think, one of the ones that comes to mind was during our response to the really devastating flooding that happened last July in Texas. And this occurred in Texas Hill Country. It's a incredibly tight-knit, very small, very insulated community. Small but mighty community health clinic that's been doing really great work there, but had never really been at the front lines of a disaster of this scale or magnitude like the rest of the community. And they were really dealing with multiple levels of devastation there. They had sort of the infrastructure that they devastation that they had to deal with. They were trying to reach their patients again, and then they had incredible mental health needs in the community that they were trying to figure out how to solve, and were very quickly asked by the state and federal government to sort of serve as the health lead to deliver all of this, and just were really overwhelmed by the circumstances. And so there were a couple of things through our training programs that we were able to do. One, we were able to put someone on the ground very, very quickly to sit with the teams and really think through how they were going to manage the health and mental health response using our training programs, using everything that we had learned, and doing it in a very rapid fashion, sort of as JR was talking about, to bring that, just the stability to the operations there. And then we were able to work with them when we were thinking about the patients that they hadn't been able to see, to use their community health workers to do sort of this just-in-time rapid training on how you can provide rapid health assessments, how you can provide some rapid mental health, very basic mental health care of a disaster, and take their community health workers out into the communities to meet their patients where they were in their homes, which was not something that they had ever done before. This was not a model that they had traditionally used. And so we were able to implement that as well. And that turned out to be very successful for them. They were able to talk to their patients. They were able to refill prescriptions, take care of people with non-communicable diseases, and bring a level of mental health care to a community that wasn't that familiar with it, or that comfortable with sort of getting mental health care or accessing or asking for it. Right. As a result of that, though, and I think what's really important is they've now made that part of their emergency response plans moving forward. So they've been able to fund that. They've been able to access a mobile medical unit, and they're continuing to provide training for their community health team on how you do this in an emergency setting, so that the next time there's a crisis of any kind, they're sort of better prepared and better able to go out and to deliver these services.
Right. Wow, that's a great story too. What about you, JR? What you got?
I liked Erica's. Erica, I did not know that that was how far down that went. I thought, oh, we need to talk. That's awesome. That's really, really cool. I'm sorry.
Eh.
I'm having programmatic envy over here. Um, I guess we'll stick with Nigeria. You got me thinking about Nigeria. So we talked about like, kind of you got to deliver the care. You got to deliver the care or the training or whatever you're doing where people are at. And there was a there's a the great the bet my favorite story from Nigeria is the story of the training baby. So were cre we created a program of three different courses, and a lot of the folks that are the most critical to the success of these types of programs are also the most busy. And one of the nurse managers in the biggest hospital in this part in one of the outlying towns had just given birth like 3 months beforehand or 4 months beforehand. And but we needed her and she wanted to be part of this training. And so she said, would it be okay if I brought my baby? And we're like, of course. And we didn't think that much of it. And then she got there, we were like, oh, this is a real baby. This is a kid, and she's got the little swaddle thing on her back, and this is the cutest kid ever. And the kid was as interested as the mom was. And so you've got the mom doing airway interventions on this mannequin, and the kid's like looking over, being like, oh, you move it a little bit to the left. And whenever she had to do something that really involved her hands or needed to present or something, the her son would just get passed from person to person, and we had like a little daycare going on. And so so it was either somebody on our team or one of our instructors would hold him and would just like he would just watch his mom the whole time. It was just the best thing ever, and it just made you happy. Anyway,
Yeah.
training baby.
Well, that's a story about adapting, right? You have to adapt to the situation that you're in. I think one of the things that's really evident from this conversation is that responding and training go hand in hand. Absolutely. And if you're going to have a lasting impact, you have to have capacity strengthening as part of your intervention. We just can't do it all and we can't be everywhere. And I think that's one of the things that's so effective about International Medical Corps' approach is that we simultaneously respond and train at the same time so that we're able to create that multiplier effect and reach more people. And I mean, you all just did an excellent job in kind of, making that real. And just want to thank you for participating and thank you all for joining us today. We really appreciate it. And as I said at the top of the hour, we couldn't do our work without you. So thank you so much. We appreciate it, and we look forward to seeing you on our next briefing webinar. So thank you. Bye, everyone.